Okay, so welcome to a talk on is trauma therapy helping? I thought this would be helpful. It was coming up in a few different areas, obviously related to current events for sure, but certainly before that as well. And so I wanted to address a few different points that I think are really important. I'm going to plan to talk for about 30 to 45 minutes, depending on how it goes. And then I'll open up for questions. You can send questions in on Instagram. You can send questions in the chat box on Zoom. And I'll look at it after I finish. So, but you can send it at any point. Okay, so I did think to start off by saying I might insult some people. I'm accepting of that at this point, because I know that I'm addressing something that people probably have strong feelings about, and I get that, I'm like, I get that, and I'm sorry in advance. I hope that you will ask your questions if something's bothering you from what I'm saying, so that I can clarify what I mean, and hopefully this will be helpful only. That's my intention. Okay, so given the challenges, like I started hinting to, given the challenges that Claudia Searle in general is facing right now, and also honestly, this is something that I've seen prior to this as well, it makes sense that we have a kind of a focus going on right now, both within the mental health world and more generally, I would say, on trauma therapy. But I want to kind of explore today whether this focus is helping or hurting. Um, I think the first time I started thinking about this topic was when I was in graduate school. A cohort member at the time, a colleague of mine, said a comment when we were taking a course on working with trauma. They said, I want to work with trauma, like they like kind of discovered that this is what they wanted to work with, not with people with real problems, or who are really, I'm sorry, I think they had said not people who are really sick. And it bothered me so much. And the reason it bothered me so much is because what they were saying really is that, I mean, obviously, I don't know what was in their head, but it sounds to me, that sentence sounds to me, is that it means that trauma is okay because it happened to them, as opposed to mental health issues are not okay because nothing happened to the person. Now, this doesn't actually make any sense. Not everybody, and the reason it doesn't make any sense is because not everybody develops a disorder from a traumatic experience or a crisis or a challenge or an ongoing difficult experience. And also, this makes no sense because people develop different problems. There's not people developing trauma. Like, people don't develop trauma. People go through experiences, and then they either heal from those experiences or they develop different types of problems. So it makes no sense to say, oh, and lots of people don't develop any problems at all. Lots of people heal and are really okay. So it doesn't really make sense to say that I want to treat or I want to help people with trauma because those I can like that they didn't have that problem that was done to them, as opposed to people who are really sick. No, anybody who is struggling with mental health symptoms, regardless of whether they went through a particular kind of experience or not, is going through mental health symptoms, and we have to deal with mental health symptoms. Um, and when we focus all of our energy on validating the fact that there was a trauma, instead of that comes at the expense of actually healing the problem. And then we wonder why people continue to suffer. People continue to suffer because we're not actually treating the problems that we're claiming to treat. We're so focused on validating the fact that something really difficult happened instead of focusing on treating the symptoms that they're struggling with. People come for help because they want, I mean, obviously some people have different feelings than other people, but mostly people come for mental health help when they are struggling with their mental health, and they want to not be struggling with their mental health. And we want that also, meaning everybody, I don't know who exactly is in our audience today, but both mental health professionals, community members, people who care about the person and the person themselves all want to have a healthier life. That's like a very reasonable goal of people going for mental health help. And validating the trauma feels good because it feels like we're saying you have these struggles. I can understand why I'm having these struggles. However, I will argue that all people who struggle with their mental health, struggle with their mental health for a reason. You're not just born, wrong. You're not just born sick. You're born with your sensitivities, your biological makeup that makes you more sensitive to different things. And then we go through life and we learn all different kinds of things that set us up to struggle with different things. And that doesn't mean that this is okay and this is not okay, or this means sick and this means kosher. Like that doesn't make any sense. So instead of focusing all of our energy on validating the trauma or focus on making the trauma the problem, we could potentially focus on the actual problem the person came for and healing that problem. I'm not saying focus on it exclusively. Definitely want to focus, strengths based and focus on where people shine, because people, even people who are struggling with their mental health have many, many strengths that we want to pull on. But I am saying that when somebody is struggling with their mental health, and we're wondering why they're continuing to suffer, it's likely something to do with not actually treating the problem. And if we're not actually treating the problem, then we have no reason to believe that the problem would actually get any better. I think that we might be kind of subscribing to the idea that, I'm saying this more like as a community, not an individual basis, but that there's like an exclusive trauma club that people who have been through good enough trauma. There's no good enough trauma. We all go through different experiences and we experience those experiences differently. So some of us are going to experience some experiences as very intense and life altering, and some of us will experience things that are more intense or less intense as, in our own ways. So there's no like exclusive trauma club for the trauma people, and the rest of the people are sick. All people who are struggling with mental health symptoms are equally struggling with mental health symptoms. Some of them have had certain past experiences, and some of them have had other past experiences. However, regardless of what the experience is, the symptoms that they're currently struggling with, they deserve to not be suffering from. Like, people who are suffering from mental health symptoms deserve to not suffer from those symptoms, regardless of whether the experience that led them to have those symptoms is justified or not, or good enough or severe enough. I think we've just rallied around validating the trauma so much so that we've lost sight of the reason that people come in the first place. Yeah. Recently, an agency who I have a relationship with told me that the biggest issue that they get calls about right now is about trauma. And it made me question, I'm sorry, prior to the more recent current events, that was what they had said. And I was scratching my head about that, because is it that we have an increase in actual trauma? Is it that we have an increase in people who have had traumatic experiences calling for therapy? Or is it that trauma has now become the acceptable way of conceptualizing problems? So regardless of whether my trauma was, X severe or Y severe or Z severe, I now talk about all of it, all of these problems as trauma, because that is acceptable, that's allowable. And I think the place where we see this the most, and I'm sure people are going to be unhappy with me here, so please, again, like I said, if something I'm saying is upsetting you or is not making sense to you, please send a question in the chat box so I can help clarify. So I think the area where we see this the most is with the diagnosis of CPTSD. CPTSD stands for complex PTSD. PTSD is post-traumatic stress disorder. CPTSD is not a diagnosis officially in the DSM, which is the Diagnostic and Statistical Manual used in America. There is another version of the DSM called the ICD, which is used more internationally. And CPTSD was recently introduced in the ICD. Top researchers in the areas of PTSD are quite conflicted about this, or I don't even know if conflicted is the right approach. I think they're actually pretty clearly not. It's not even discussed very much at all, because there are people who are advocates for this diagnosis and who very much discuss this diagnosis and are very invested in investigating this diagnosis. However, most of the academic world around PTSD, this isn't really even on the table. Why? Because this diagnosis essentially maps directly onto the same exact symptoms of borderline personality disorder, except one small difference I know what the difference is. The one small difference in the criteria is whereas in CPTSD they say there's persistent negative self-view. In borderline personality disorder, it's more labile. It's more touch and go. Like I view myself positively or negatively can shift, or more of a shifting sense of self. So that is something that they've identified as different between these two diagnoses. However, and people also say complex PTSD is particularly for people who have been not through, that PTSD is for people who have been through one or like a single episode of trauma, versus complex PTSD is for people who have been through an extended period of trauma, for example, childhood sexual abuse that went on, as opposed to a sexual assault, which is a one-time event. So there's a couple problems with this. So first of all, identifying a diagnosis by the by something that happened as opposed to by the symptoms is confusing. We don't usually do that. Like we don't have we don't have like Lyme disease that was caused by this versus Lyme. Like we don't treat differently diseases that were caused by different causes. We treat the disease based on the disease. So the same exact thing here. CPTSD, just because it came from a different experience, doesn't mean that the symptoms are going to look different. Again, this is going back to what I was saying before about how we're identifying the it's so hard to talk to not seeing any faces. I respect everybody's privacy, and I'm talking to myself. It feels like I'm talking to myself here. So if you want to take off your screen for a second and wave, I would appreciate it. Okay, so CPTSD is basically kind of making the diagnosis around defined around the experience rather than around the symptoms. And if you focus on the symptoms instead, you actually really get a picture of borderline personality disorder. Now, I think people get really mad about this. People actually get furious about this. And why? Who cares? Why do people get so mad about this? And that goes back to what I was saying before, that we feel that trauma is valid and mental illness is invalid or wrong or trafe. And that is terrible. That's really terrible. Although I like to say, I think anxiety we've kind of made okay at this point, but pretty much anything else, mental illness is wrong and bad, but trauma is okay. So CPTSD feels so valid. I went through a horrifying experience. I have CPTSD versus I have borderline personality disorder. Borderline personality disorder is a very severe diagnosis and has a lot of stigma attached to it. So it's much harder to swallow that diagnosis. It's much more comfortable to say CPTSD. Who cares? Well, if you're going to have an entirely new diagnosis, then you need an entirely new treatment. However, the only actual evidence-based treatment that I'm aware of for CPTSD is STAIR, which is essentially another version or whatever, an updated version, or not even updated, that's not the right term. Essentially, it is a treatment built around the same core principles or very similar core principles to DBT, which is an evidence-based treatment for borderline personality disorder. So do you hear where we're kind of getting stuck here? That now we're reinventing the wheel for a new diagnosis that feels more valid, but that actually isn't giving us anything new here. Because guess what? Lots of people with borderline personality disorder have very severe trauma histories. Not everybody, but many, many, many people do. And it's actually very, very common for people with borderline personality disorder to have quite severe histories of trauma. But that is kind of it's not as acceptable because borderline personality disorder is seen as very bad, and CPTSD makes it about the trauma, which is acceptable. I do see someone sends in a question, but I'm going to save it for the end. Okay, so that's my spiel on CPTSD. I hope that explaining that my intention was really to help use that as an example to help explain my other points. Okay. So like I was saying before, calling somebody's problem trauma is like calling any mental health symptom the history of the symptom rather than the symptom itself, which makes no sense. It just doesn't make any sense to do that. Trauma is not a symptom. Trauma is an experience, or whatever, you can define that word in many ways, but a traumatic experience is not a symptom. Many people go through traumatic experiences and don't develop mental health symptoms. Many people go through traumatic experiences and develop OCD or psychosis. So why say that this is trauma? What are we treating when we're treating trauma? What do we treat when we say we're treating trauma? What are we actually treating? Because we're treating symptoms, we're treating problems, we're treating, the problem somebody came to therapy with. We're not treating an experience. Trauma is part of a history, just like lots of other learning experiences. Like somebody could have gone through a traumatic event or a traumatic series of events, and they also have lots of other learning history, like how their parents treated them and how their school treated them and how their community treated them and how they related to emotions as a boy or a girl growing up in this area in this time period. So all of that impacts us, just like, obviously, but just like traumatic experiences influence and impact us. So when you're looking at somebody's current problems, making it all about the traumatic event is like losing sight of so much, because there's often more of a picture than just that experience. So PTSD, post-traumatic stress disorder, is a disorder that might come out of trauma, but so is OCD, so is psychosis, so is many, many other mental health disorders. Trauma therapy sometimes implies that the therapist should do something to make the client feel safe. Or I've heard therapists say, like, I'm their only safe person, or I'm the only thing that grounds them. My issue with that is that is not therapy. The question, I mean, obviously people can define it differently, but therapy, theoretically speaking, is a treatment. Is being a safe place or being a grounding force in a person's life, is that treatment? I don't know. Doesn't sound like a treatment to me. It doesn't sound like things are getting better. I would like that when people come to therapy that they are on a path towards getting better, for however long that takes. I won't argue with, but I will argue with that things should be moving in the right direction. And therefore, doing things that are outside of an appropriate therapeutic relationship is not therapeutic. So I think this is particularly tricky for people in the frum community, because we do so much chesed that is not standard outside of our community. And therefore we're more likely, I think, than other communities to fall into this trap. It's not, it's not the worst trap. There's other traps, but I do think we do fall into this trap of providing things that are not therapeutic. And if you're a therapist, I remember one time working with somebody, and I had the thought several times, like, gosh, I wish I could invite this person for a Shabbos meal. I knew they lived in a close enough to where I lived. And I knew what they were struggling with. And I kept just like wishing I could do that, but I didn't do that because I knew that would make me unable to be their therapist, that I would not be able to provide therapeutic intervention. Why? Because therapeutic intervention needs to be provided within the framework of therapy. The framework of therapy involves certain kind of frames that keep it therapy and keep it therapeutic. We only meet within a certain time frame. When we meet, we don't talk about me unless I'm using me as an example, or me to kind of model, or me to kind of bring the tension down in the room. But we don't talk about, I am not in this therapy. My mental wellness is not in this therapy. Your mental wellness is in this therapy. And so I am going to be treating that, and that's going to be the focus of what we're doing for this pre-specified period of time. And we're going to actively work on these goals together over time. So this is what has to more or less be happening in therapy. And if it's not happening in therapy, if there are other things happening in therapy, then, it's a question mark. Is this therapeutic? And I think that's what we need to be asking ourselves in general. What I'm trying to raise here is this therapeutic? Yeah. I also wanted to just clarify as a subtopic of this topic, why I don't recommend and why the field of psychology in general, and particularly where psychological science is, at least for the last 10 years, for sure, actually, a little older than that, because this is for sure since 9/11, when it was very obvious what was not working or what actually caused harm. We don't run for trauma therapy in the face of crisis. And the reason why is because the things that are healthy to do in the moment are not treatment. And actually, what we have very clear research about is that treatment during a crisis can be harmful and can actually cause worse problems. That is something that we saw as a result of 9/11. You can easily search for this yourself. I'm not making it up. That we saw that things that were provided in the immediate aftermath, particularly what's called debriefing, was considered was actually caused harm. So what is helpful to do during or in the immediate aftermath of a crisis? Essentially three things. Those three things are promoted through methods called like psychological first aid or mental health first aid. I think there's maybe another one, but they're all talking about the same thing. And they're basically essentially a couple, core things that have to happen. One is establishing safety. If a person went through a hurricane, so that was like the example when I was trained. A person went through a hurricane, like making sure that they have a place to sleep, that they have a way of contacting their loved ones if they don't have their phone, or if there's no service. Do they have clothes? Do they have food? Like basics. So connecting with safety and helping establish physical safety. The next important thing is connecting them to existing resources. So I don't want them having therapy during the crisis. I want them connecting with the resources they already have. Can you speak with your mom? Can you speak with your best friend? Can your best friend come here to talk with you or to be with you right now? So connecting them with the resources that they already have is really important. And then the third one, in my opinion, like the most useful thing that can happen is facilitating or promoting or supporting healthy processing. So what we want happening within the first few weeks after an acute stressor or a crisis or a traumatic event, what we want happening in those first few weeks is we want healthy processing to be happening. How does that happen? So when the thing happens, we are in the thing, but right after the thing happens, we start to move the thing into being part of our brain. And I always give the example here of a quote from a Lemony Snicket book that I read when I was a child. And the quote is something like, losing a loved one is like walking up the stairs in the dark. You think there's you think there's one more step than there is, and your foot dangles in the air awkwardly, something like that. I don't know the exact words. Dangles in the air for an awkward moment or a sickly moment before it lands and realizes that there's no stair there. And I love just that metaphor, that visual, to explain this. Basically, when a traumatic event or a crisis or a massive challenge happens, we need to kind of synthesize that experience happened. It's kind of like we expected life going this way, and then all of a sudden this happened. And now I have to expand my brain to accommodate for that other piece of information having happened. And that is harder than it looks. So things need to happen in order to make that happen, in order for my foot to land on the floor. What needs to happen is I need to kind of process and not let it get stuck in my head in unhealthy ways. So I might get stuck in my head of like, this was all my fault. Or if I would have done this, then this would have happened, or then this never would have happened. And we kind of get stuck in that. And what we need to do is find healthier ways of processing that experience or integrating that experience in a healthier way. Now, within those first few weeks, we can integrate in a healthier way. How can we do that? By talking it out, or just I always say, just like getting it out of your head. So you can do that by talking it out, because as you talk it out, it becomes obviously so logical that this wasn't your fault. There was nothing that you did that made or didn't make this happen. That becomes obvious as you talk it out with somebody. That's not obvious when it's stuck in your head. But when you say it out, it's like, well, that makes no sense. And you can, and often people will say it themselves, but as they're saying it out, that's what happens. So talking about it with a therapist is lovely, but again, it should be talking about it, just talking, not doing anything with it, just talking about what happened. It could be talking with a friend or a parent or a sibling or a spouse or anybody or anybody at all. So yeah, we want to have some way of getting it out. Talking is great, but it can also be other things. It can also be making some form of art, expressing this thing, making a song about it, or singing any song that you feel is related to the topic, or moving it out. Sometimes people find it really helpful to like dance out or just move out, like kind of like what you're feeling inside. Obviously talking, I think, is the most common or logical for some people, but for some people other forms of expression are helpful. So I just like to share that there's many roads to Rome. And essentially what we're looking for to happen is to have it just not be stuck in my head and to exist in the world, for me to make sense of it in the world. After several weeks, if I'm still experiencing the same symptoms I experienced in the beginning, because all symptoms in the beginning are normal, all symptoms in the beginning are normal. That's the normal response to shock, and that's what I'm calling it, shock, is all the things that we would look at as a mental health problem if they were 6 weeks or 8 weeks or 10 weeks later or 12 weeks later. Different. She told. But if they were happening several weeks later, then we would be considering that a mental health symptom. But if they're happening in the immediate aftermath of a traumatic experience, then those are totally normal. But those will subside with that expression or that processing or synthesizing. Some people that won't happen for. They're going to get stuck in, let's say, for example, this is my fault. And with that stuckness, or whatever, there's many ways to explain this, but I'm going to explain it this way for now. Then they develop those symptoms. So what we want to do then eventually in therapy, is to healthfully process that. And then it's going to take maybe a little more effort at that point. But it's very, very possible, very doable. PTSD is very treatable. OCD is very treatable. Many things that can come out as a result of a traumatic experience are very, very treatable, and we deserve to treat them, rather than focus on the fact that a traumatic experience happened. Okay, so I wanted to also talk about non-professional or inexperienced mental health workers. I don't want to like put anyone down. I just want people to I really just want people to understand the basics of how different mental health things work, and therefore be able to make their own educated decisions based on that. Yeah. And where we see this coming up, I think, and as I was hinting at this earlier, is that within the Frum community, we often have devoted or caring mentors or teachers or rebbeim, or I mean, it could be a Chal teacher, it could be so many different types of people. But what happens is that not because people are untrained, but because people are coming from their caring, devoted selves, the automatic reaction is to give more attention to the trauma or to the and to help the person move away from the distress, which actually, if you understand what I was saying before, is the opposite of what's helpful. What's helpful is moving towards the distress and being present with the distress. You would think that helping the person distract or calm down would be helpful, and that might be helpful for part of the time or be part of the picture, but most what needs to be happening is actually sitting with the distress and coming towards it and processing it and putting it into our lives, making it make sense, making it a part of our experience, allowing for it. What happens with devoted, caring, loving people is that they are going to automatically, intuitively try to help people turn away from their distress. And non-professionals or inexperienced mental health workers might do similarly. So that's the caution there is if the mental health provider or inexperienced mental health provider or non-professional person, caring devoted person is encouraging turning away from distress, then that is where people are going to ultimately get stuck and have more severe mental health symptoms in the long run, unfortunately. I do want to also just note on the non-professional side, giving out medication for the sake of helping to lower distress, even when the stress is very, very high, is unfortunately actually it's doing the same thing. It's not allowing for sitting with the distress, which would be the healthy and healing thing. It's turning the person away from. It's also illegal to give out medication if you are not a prescriber of that person. So I'm putting that out there because that I have heard about that. But so that's one thing. But also understanding that what it's doing is not promoting healthy healing. What it's actually doing is promoting turning away from the distress, which is making us get more stuck and suffer more long term. I wanted to also just note on the word triggers. Anybody who works with me knows that I don't like that word. The reason I don't like that word is because, first of all, the word itself, and there's a lot of words that I don't like because they tend to be inflammatory themselves, and they are non-specific. Although we all know what we mean at this point, they've become part of our vocabulary. They do kind of promote certain feelings and certain connotations that I don't think are helpful. So particularly on the word triggers, trigger is what does trigger mean? Trigger is something on a gun. So it already is a word that is quite inflammatory, that has carries a lot of significance and heaviness. So it's a heavy word to begin with. And then we're using it to mean something that causes a bad reaction in me and therefore should be avoided. And you should also protect me from it. So this goes into the same thing I've been talking about, that you're keeping yourself from experiencing the thing, from processing the thing, from allowing the thing to heal, whatever the thing is, so that we don't end up with mental health symptoms. Instead, you're actually promoting avoiding the distress, which promotes staying stuck in mental health symptoms or producing worse mental health symptoms, because I can't handle this. So my distress is going to get higher. My ultimate problems are going to get higher. In the moment, I'm going to feel better though. So if you take away my trigger, you don't trigger me, I will feel better now, but I will have worse mental health in the long term. So okay, those are kind of all the points I wanted to discuss. I wanted to also just kind of, on a positive note, the good news, or what we can celebrate, is that we actually need less, not more. In response to traumatic events, we need more. We need lots of love and support and care, but we don't need to protect people from their emotions. We don't need to protect people from their distress. We don't need to make people not feel bad. We just need to be there for them in their feeling bad, to allow it and to allow them to move through it, because the uncomfortable or the negative feelings are there as signals, and they are intended to help us move through them and get healthier through them, and integrate them into our lives. So I'm going to turn to questions now. I see a couple of questions coming out of the chat box. So somebody posted, I think there's a lot more awareness today of how different types of trauma affect people, and especially lack of good attachment in childhood. I think this is why many people are seeking out treatment for trauma. Yes, I think that there's a lot more awareness of different things that can affect us, but I think that we are therefore calling it trauma. Because I'm aware that this can affect me and this can affect me and this can affect me, I'm therefore going to call many different experiences trauma and focus on trauma rather than actually what I'm struggling with, which is it's kind of it's like losing the point. It's like focusing again, like I said, focusing on where I got the illness from. I caught this from my child in kindergarten, rather than focusing on what are my symptoms that I need help with. It doesn't matter that the kindergartner brought the disease home. What matters is my immune system is weaker than theirs, and I'm struggling with greater symptoms that are impacting my functioning. That is what matters, and that's what I need help with. So it doesn't matter where it came from. So yes, there might be more awareness of different things that affect us, but yes, many things affect us. And I don't think that's new, that's like new information. I do think that that's whoever posted that, you're right, that that's creating more of a drive for people to get help with these things. But I also think that it's like making us lose sight of what the actual problem is. And I also think it's creating a ton of pressure on today's young parents to be perfect parents, which is not functional or healthy either. Children do need to see parents experience emotions and like deal with them in a healthy way. Children do need to see parents apologize for mistakes. If children see perfect parents who never mess up, then something must be wrong with them because they mess up all the time. So that's not healthy either. I do think that's unfortunately creating a lot of pressure in terms of that. Okay, how is talking about the trauma different than debriefing? So debriefing, again, I don't know. I wasn't in that what they were doing exactly in post 9/11. However, what I'm talking about is facilitating talking, meaning I don't say anything, and whatever's on your mind, talk about anything. You want to talk about rainbows? You want to talk about the weather? Talk about whatever you want. Versus facilitating focused treatment on the problem, or talking about particular things, or having to talk about the experience right now is not helpful. But facilitating talking about whatever's on the person's mind. And by the way, this we kind of know this already from the Minhagim of Avelos. In Avelos, when a person visits an Abel's house, what are we told to do? We're told to not say anything. And let the person speak, and the person can speak about whatever they want. There's no rule that they have to talk about something in particular, but they can talk about whatever comes to them. And this kind of forces them to be in their feelings and to ultimately kind of move through the processing of this loss. And moving through that processing of this loss comes through this process, this of sitting in the sadness and focusing on it, more or less, and having the space to talk about it. Can I give an example of that last point about triggers? I mean, examples abound. It depends on what the person's trauma is. I've heard people say even like very silly things, like very funny things, like I went through a religious abuse, so I am triggered if I hear if you use Jewish words. I've heard people say something like that, let's say. So what they really mean is I went through difficult experiences relating to religion. I have difficult feelings that I have not worked through relating to those experiences that I've not resolved, or that I feel still unsettled about. And when you say a Jewish word, my head connects it with those experiences and I start feeling distressed. That's what they mean. But they're not saying that. They're saying you're triggering me. And therefore you have to stop. This is, some people call this cancel culture. You have to do what you're doing is bad. Stop it. Rather than actually, I am experiencing something unhealthy and I have to work through experiencing that so that I can have a healthier life where I can approach and deal with the things that are uncomfortable or difficult or painful for me, which this made up person I just invented deserves to do. But there are many, many, many examples of potential triggers. A client with an eating disorder saying I'm triggered by being at the family simcha that's going to have a lot of food at it, or the family yontif table, so I have to eat by myself. Now, when a person is in a certain stage of eating disorder treatment, we might want to do that because we want to just facilitate. They have to eat, like that has to happen. You can't live if you're not eating. So therefore, we need to have you eat. So we're going to do whatever we can to make that happen. But at some point, that is not functional behavior. That is not what we want to be doing for our lives, even though it triggers you. So what we want to do is allow you to, like, let's facilitate what could happen if you come to the family simcha. There's going to be food and you're going to have thoughts about that food and you're going to have feelings about that food. And what are the thoughts and feelings going to be? Let's deal with that. So that would be more toward, like, in the spirit of or towards healing, in my opinion. What is the treatment for developmental or attachment trauma? So I don't use those terms. But I think what you're referring to is traumatic experiences that happen early in our development or in our primary relationships. And so I don't focus on when or how it happened. I focus on what the person is struggling with. So I don't care if it was developmental trauma or attachment trauma. I care if they are struggling with hypervigilance, flashbacks, nightmares. Are they struggling with inappropriate relationships? Are they struggling with self-harm? Are they struggling with an eating disorder? Are they struggling with negative thoughts about themselves? Are they struggling with depression? Are they struggling with bipolar? What are they struggling with? That is what I want to treat. And regardless of when their difficult experiences happened, what if the problem is no feeling? So more of like a numbed out. So that if that's the problem, like if a problem is if a person is experiencing disconnection from their emotions or feeling more numbed out or dissociation, like it can be like all those things or none of those things, or it could be a spectrum. So we want to deal with that, right? If we want to help the person to experience their feelings, I'm usually going to use a mindfulness to emotions based approach. I'm not going to do that usually first. Usually people who are struggling with numbness are also struggling with several other things that I'm probably going to want to deal with first. But at some point, I'm going to want to get to that. And I want that person to be able to tap into and experience their emotions more fully. And so I'm definitely going to want to work on that, usually with like a mindfulness to emotions based approach, which is basically drawing attention to the thoughts that show up, the body sensations that show up. What does that emotion feel like? Can they sit with it instead of kind of running away from it? So usually there's like an emotional avoidance element, or like an intolerance to sitting with emotions. There's usually like a 0-100 effect. Like they're mostly, let's say, zeroed out on their emotions, and then sometimes they're hitting hundreds. And so I want to make sure that I'm enabling or facilitating them hitting 20s and 30s and 50s and 70s, and noticing those and experiencing those. Okay. Doesn't source of symptoms matter in terms of understanding actual issue and treatment? Absolutely. You need a solid conceptualization in order to develop an effective treatment plan. But a conceptualization is not treatment. This I stand by very strongly. Conceptualization is not treatment. I do think that some people spend a lot of time developing conceptualization, meaning developing understanding of what the problem is before they're actually and never addressing treating the problem. Understanding the nature of the problem should be something that we do automatically within the first very short period of time. We should have a solid, as I'm saying, the treatment provider should have a solid understanding that they share collaboratively with their client. Obviously, there's different treatment modalities, and I'm not saying there's only one right treatment modality. I'm just saying that clients should be aware of what that conceptualization is, more or less, to understand the nature of the problem, why that problem developed. So very early on in treatment, I'm formulating my understanding of how this problem came to be based on my assessment. So yes, early experiences, or not just early experiences, all of life experiences are going to impact how the problems that are showing up today. That's for sure. And that doesn't mean that treatment is going to focus on the experience. Treatment is going to the experience might be part of treatment, depending on what the symptoms are. For example, like I was saying, right, there might be some kind of processing of the experience that needs to happen. So that is going to have to happen if that's part of the problem, if that's part of the presenting problem. But that might not be part of the presenting problem exactly. In which case, I'm always going to be 100% focused on a solid conceptualization based on their full life experiences, and therefore a treatment plan that's based on that conceptualization, which is going to include their history, of course. So source of symptoms matters very much. Wouldn't you say that different issues can present in same way, but may need to be treated differently depending on the cause? For example, inability to pay attention. So that's, I think that's interesting how you phrased that question. Different issues can present in the same way, but may be treated differently depending on the cause. So yes, inability to pay attention could be so many different things. So actually, a great example of that is that sometimes people think that somebody's depressed, but they actually have PTSD. And people with PTSD will have low mood as part of their symptoms. So the answer to that really is that you have to have a better conceptualization. Your conceptualization should capture And your conceptualization, I don't know if I explained this, it means your way of understanding the presenting problems. Why do we have these presenting problems? So your conceptualization needs to include everything. So sometimes you'll see people will get like 5 different mental health diagnoses. Yeah, they have PTSD and depression and anxiety and ADHD. They probably don't. That's very unrealistic. Some people have ADHD and depression, but like, or ADHD and anxiety. Actually quite common because the medications like cancel each other out. But I didn't say that correctly, but fine. But they probably don't have all 4 of those. That's very, very unlikely. So you do have to have like your diagnosis should make sense for the full picture. So inability to pay attention could be ADHD, it could be PTSD, it could be severe emotion dysregulation. It could be anxiety, like it could be psychosis, there could be like an internal preoccupation. It could be this just such a high level of distress that I can't focus on what's happening because my distress levels are so high. So yes, you need to understand what I call the function of the problem. Like, why do we have this problem? But it doesn't matter. Yes, like you will need to treat the problem differently based on where the problem's coming from. But that has to do more with my understanding of the problem, not with whether it was developmental trauma or motor vehicle accident trauma, or whether it's trauma or ADHD. Trauma is not a symptom. Trauma is not a mental health condition. PTSD is a mental health condition. So it will matter if it's PTSD versus ADHD. Yes, that matters. But PTSD is a set of symptoms as a result of like that come after a traumatic experience. But many other mental health issues can also come after traumatic experiences. Okay, how to help someone that has tried many therapies, many modalities, many medications, and yet still is stuck on their triggers/traumas. That's, you literally answered it in the question. Of course, they're not better. And I just feel like sad for them as I'm reading it. The many therapies and the many modalities and the many medications are not going to be helpful as long as they are stuck on their triggers and traumas. There needs to be a willingness to or some level of willingness to not spend their lives triggered and in response to their trauma. If you want to build your entire life around your trauma and suffer, the consequences of that, everybody is entitled. But no, don't delude yourself. That I always say this, like, you can go to therapy then to just like say that you're in therapy, but go to like somebody who, at least go to somebody who takes your insurance then. Don't waste resources in your own life or somebody else's resources, worse, on going to therapy that you're not going to use. Because the person who is focused on, I have a trauma, therefore I have to stay ill forever, there is no willingness to change. That no therapy and no medication and no modality is going to change anything because they are committed to avoiding their triggers and living a life in response to their traumas. Very sad, but that's actually quite, common. That's basically what I'm addressing today. Yeah, they can't move forward with their past. Yeah, they can't. There has to be some willingness to say, I don't want to live in this anymore. And I'm willing to experience things that, and I'm going to say this, what does trigger mean? I'm willing to experience the things that are difficult and uncomfortable for me. I'm willing to experience the things that set off negative emotions for me because they remind me of challenges that I've had, because I'm willing to heal from it. There has to be a willingness to do that, as painful as it is. And you can have all the support and love and help in doing so, but you have to be willing to do it. And some of us are very committed to our identity as trauma victims because it's very validating. That's what I was talking about with CPTSD. It's very validating. So yeah, that's what I'm going to do. Okay, I had an experience where I'm not sure what it sounds like a not quite word, where for years I did DBT and CBT, and I felt this really heavy burden of my childhood pain weighing on me. No therapist encouraged me to unpack it. Eventually, as over years, I felt confident enough to seek out a trauma therapist who would be okay addressing it with me, and I found it very helpful. How do you see that? So I'll tell you a few things. First of all, so again, I'm not married to a particular modality being right, unless unless it's evidence. Unless we're talking about evidence-based treatment versus non-evidence-based treatment. I believe you should always at least start with evidence-based treatment before moving to other options. So that's number one. But aside from that, though, very often people go for something like DBT or CBT, and they miss that part of treatment. So in DBT, for example, okay, a few different things to address here. In DBT, for example, DBT works in stages. So stage one is typically decreasing life interfering behavior, therapy interfering behavior, and quality of life interfering behavior, and improving skills. And then stage two is trauma processing, treating trauma, and encouraging emotional experiencing. So sometimes people just don't get to stage two. Or some therapists don't move to stage two, which is a different problem. But that can be a very real problem. So that might be one part of the problem, is that was never moved to. And in terms of CBT, if a CBT therapist is going to focus first, somebody who is offering CBT as the modality is probably offering that in response to the current symptoms. But if the current symptoms are a result of if the current symptoms are being driven by childhood experiences, then those then that frame has to be addressed. And the reason I'm saying this is because actually two of the treatments with the strongest evidence for treating PTSD are CBT based. One is prolonged exposure, which is a behavioral treatment, and one is cognitive processing therapy, which is a cognitive treatment. And both of those modalities have the strongest evidence, and they are behavioral and cognitive treatments. So they are definitely addressing childhood experiences if that's the identified trauma. However, the person who is doing the treating has to have an accurate conceptualization, which is why it should be collaborative and you should be part of that. If you found the trauma therapy helpful, so I'm curious what then I would be, you don't have to answer this, but I would be curious what the trauma therapist did, what was helpful. So it might be that they did elements of prolonged exposure, for example, kind of giving you space to talk out your experiences and to process in a more healthy way aspects that you found that maybe you got stuck on, or cognitive processing therapy where you kind of shared where you got stuck, like this was all my fault, for example, like an example I shared before. So for example, like this is all my fault, and then, kind of working through that, like, is that accurate or not? So probably I'm assuming that if it was helpful, elements of that happened in the treatment. Yeah, I hope that answered it. So it's not that like one modality is correct, one modality is incorrect. It's that treatment has to be addressing the full extent of the current problems with a really solid, accurate conceptualization. If it's not doing that, then it's not hitting all the pieces. But I don't think it's that DBT and CBT don't address childhood experiences. They address whatever the person is actually struggling with. If you want to if you want to share about prior experiences with somebody, that is like, it depends on what's the function of that. Like, what is that doing? So the person wrote that they did inner child work with me, and the previous therapist just always focused on symptoms. So, I think let's break this down a little bit more. First of all, if the previous therapist focused on symptoms, did they treat the symptoms? Did the symptoms resolve and you felt better and you no longer had distress? It sounds like not. It sounds like you still had distress. So they were not addressing those symptoms. So that would have been part of the picture of what had to be addressed. That's one. And she did inner child work. So there, all these modalities like that focus on, let's say for example, like inner child work, you have to ask what's the active ingredient, like what about, or what we call like mechanism of change. What's the mechanism of change for that treatment? And what I would say is that any treatment that is actually treating PTSD or an anxiety-based issue is going to have to be addressing is going to have to be providing exposure in some fashion. So probably what was happening in some version is you were talking through the experiences as an adult, looking or as somebody, away from the experience, and working through it in a healthier lens. So that was happening. And that I would guess would be the mechanism of change, but obviously I wasn't there, so I don't know exactly, but that'd be my guess. Okay. Do you think it's always a choice to step out or sometimes not in the person's control? This, honestly, the best way I can answer this is like Mechta Miliyahu Nikudas Habachira concept, meaning we all have different areas of where our choice point is. And where our choice point is can move. And the more mentally ill I am, the weaker or the further my choice point is. That doesn't mean I don't have choice. I always have choice, but that might be a lot harder for me. So for example, somebody who's very deeply, like I was bringing up the example of somebody with an eating disorder before, somebody who it's even a problem for them to eat anything at all, and we just to get some food into them, for them to go to a simcha, it's not the wisest thing for them to do, not because they can't handle it, but because we have a goal and we want to make sure we reach it, and it's going to be much, much harder with that added stressor. Let's make it as easy as we can. Yeah. However, that doesn't mean it's not in their control and that we can't move them towards making healthier choices overall independently without needing that extra buffer from pain. So same thing with triggers. Something that's, yeah, and I'll say how I define a trigger, what people probably mean when they're saying triggers. Is it in my control that I have an emotional reaction to something that reminds me of a difficult experience? Sort of, but not fully. So yes, I have my own reaction. That's my reaction that shows up. It makes sense that that reaction showed up given my past experiences. And I don't have to have that reaction show up. That reaction doesn't have to be showing up. It is showing up right now. And what I can do to make it show up less is when it shows up, I can sit with it and allow it instead of, oh no, I have to make it stop or make it go away. I can allow it, and then it will become easier and easier, and the reaction will become less intense because my brain learns basically that I can handle it, that it's not that it's a memory. It's not actually dangerous now. And that learning happens. So the person who was asking before about the inner child work, the previous therapist helped for a short period with depression and anxiety symptoms, but not deep issues like relationship issues and self-esteem issues. So yeah, it sounds like they probably weren't addressing the full extent of the problems. So what you would want to do is, like, theoretically speaking, is you want to treat the full extent of the problems. I would, when somebody says they have relationship issues or self-esteem issues, I always push further to understand what exactly that means. And then we want to treat those issues. But that doesn't mean that we need inner child work because of trauma, because I've been explaining this entire time, that is non-specific and tends to, and it's the focus is on band-aiding. The focus is not on healing the problem. If the problem does get healed, it's probably as a result of some form of exposure happening, but unintentionally. And so I would rather let's address the problem. If the initial therapists weren't addressing the problem, it sounds like they did not have a full handle on the presenting issues, like the actual full presenting issues, which were not just depression and anxiety, and that their treatment plan didn't involve treating those. So it sounds like, those would have to be addressed. Welcome. Any other questions or reactions or things I can be helpful with on this topic? This is a topic that has been very much on my mind. It has come up over and over and over again, definitely over the last several years, but certainly in the last month and a half, lots. And so I wanted to address it and provide some perspective on these things. I hope that it is helpful. Yeah, and I'll give another minute for any other questions. I will, Bezrat Hashem, post this on our YouTube channel. If you go on YouTube and you search CBT DBT Center, you'll see our logo show up. You click on there and it will be there probably within 24 hours or so. Yeah. I know people who are hurt by trauma therapy because it opens up things too big. So that is, again, why it's not about opening up the thing. It's about understanding the current problems and then treating it in a healthy and functional or effective way. So for example, I'm just using DBT as an example. It's not the only approach, but I do think it just gives a nice framework for the approach. So DBT, people who come to DBT often come in with severe emotion or whatever, some version, some level of severity. of emotion dysregulation, and they very likely also have some type of avoidance of emotions or avoidance of experiencing emotion, difficulty with experiencing their emotions, and very likely have a history of trauma. So I would not want to, and actually, it's not uncommon. It's actually quite common for us to get clients for DBT who have been in trauma therapy that has had that problem. And that it's because the person is emotionally dysregulated and behaviorally dysregulated. Those are their current problems. So we treat those problems first, but then we do treat the trauma. But you got to treat both, but you got to treat them in order and when the person's ready for it. So yeah, it's not because a person has experienced a trauma does not mean that you need to open up the trauma. That is not what that means. I think that's like kind of the summary point of this whole talk. A person who has been through a trauma has been through a trauma. End of the story. Not end of the story, but that's the end of that sentence. That doesn't mean we therefore have to XYZ. We don't have to do anything. We have to treat their problems. So the highest thing you're going to treat is always life interfering issues, safety related issues is going to be what you're going to treat first. Establishing the ability to tolerate distressing emotions is going to have to be higher priority than opening up the difficult experience. So yeah, we're going to have to kind of go in a healthier, effective order. How long can we leave a student with trigger avoidance after they experience the trauma? So yes, that's a really great question. I will usually say, listen, take it easy, but also be moving. So the answer is like kind of two parts of the answer. Like you can be gentle with yourself. You can say, this is hard and I'm not going to do this all the way right now. That's fine. As long as you're moving in some sort of direction. Meaning, if you are 100% avoiding triggers, whatever, then you are going to get worse. Like I can pretty much predict that. If you are avoiding some because it's really hard right now and being like, being gentle with yourself and taking it slow, that's fine as long as it's moving in the right direction, meaning like it's getting better. You are avoiding less and you're feeling better with time. That's fine. Take your time, take it slow. You don't have to do it all right away. So let's say I have a traumatic experience in this location, this particular location, and therefore I'm avoiding this location. I don't have to go to the location tomorrow, but I should walk by or at least be able to go in like the neighborhood. And then, a couple days later, go to the location. And the few days after that, go like really towards, the location. So, it should be moving in the right direction. Why? Because the more that I avoid the triggers, the worse my symptoms are going to get, the worse I'm going to get in the long term. So yes, it can be okay to avoid somewhat for some period of time, but it should be moving in the right direction always, even like from moment number one, we should be moving in the right direction. Okay, yeah. Any other questions? Okay, yeah, so we will load it onto our YouTube channel. Anybody who wants to see it who does not have access to YouTube, you can email us at info@thecbtdbtcenter.com and we can share a link to it with you. And I hope this was helpful and I hope this helps create change in people's lives and people, getting more effective help and moving towards the life that they want to live instead of being stuck in experiences that were difficult. Yeah.
Thank you.
Yeah. Thank you to everyone saying thank you. Take care.